We are live, everyone. Good evening. Welcome to today's masterclass. It's chapter 52. I welcome everyone and invite our immediate past president, Dr. Arnab Gupta, to kindly deliver the welcome address for today's masterclass. So,
Thanks, Dr. Srijan. Good evening, everybody. It gives me immense pleasure to welcome you to this masterclass. It's amazing how time flies. It started way back in October 2021, if I'm correct. And since then, this is the 52nd chapter. And this was only possible because of the leadership by Dr. Subramanian Rao. We had academic council, obviously, from 4 different zones, all the past presidents. But it would have never been possible without the active kind of leadership of Dr. Subramanian Rao. And he was obviously ably kind of supported by Dr. Srijan Shukla. There's no doubt about that. So today's topic, I understand, is peritoneal metastasis and local recurrence in colorectal cancer. And obviously the examiner and expert talk is going to be from Dr. Ramakrishna, a good friend of mine from Chennai. And we have Dr. Bhavna Parikh as a moderator from Ahmedabad. And obviously in the academic council, we have Dr. Sanjeev Mishra, Dr. Sadasivam, and Dr. Rajgamit Sharma, for all past presidents. And we understand have the examinees, 2 of them, Dr. Pratham Batra and Dr. Pushkala S. So I really congratulate this academic council because most of these, the academic master classes are actually on the YouTube. A lot of people are getting benefited. I'm being repeatedly told by many people that they have been kind of successful in the exam because of this master class. They are now more oriented. The topics are becoming more and more difficult, yes, but then this is how you got to improve yourself. So once you've gone through the basics, this is the time you fine-tune your other skills. And this may be in the clinics, it might be in the question papers, also in the theory paper, how to deal with difficult situations. So without wasting any more time, I would request the organizers to take over once again. Thank you.
thank you, Arnab sir. Our examiners for today, Professor Ramakrishnan, who is the professor and head of GI and HPB unit at Cancer Institute, Adyar. And the moderator for today's session is Dr. Bhavna Parikh, who's a consultant at Sterling Cancer Hospital, Ahmedabad. She has worked previously in GCRI Ahmedabad and Asian Institute of Oncology, Mumbai. And she has many publications in various national and international journals. The examinees for today are Dr. Pushkala S. from Cancer Institute, Adyar, and Dr. Pratham Batra, who's from Kidwai Memorial Institute of Oncology, Bangalore. Few instructions for our examinees that we request you to give the answers to the point. And if you don't know something, just mention it so that the examiners can move on. It will save us time and maintain the the flow of this webinar pattern. For our moderator, Dr. Bhavna Parikh, we request you to ensure that both the examinees get equal opportunities to answer, and request both the examiners to address them by name when asking a question so that there's no confusion and the examinee know that who is supposed to answer. In interest of the viewers who are online with us, as well as people who are viewing this on social media later, we request the examiners to give the correct answers to the incorrectly answered or unanswered questions. For our audience, we appreciate your comments in the chat box. We will include that in the Q&A session after the expert talk. As for timekeeping, I will message our examiners on the chat box at 30 minutes and at before the conclusion, 5 minutes before, which would be 60 minutes. The first mock exam would be given 60 minutes. With that, I request our moderator, Dr. Bhavna Parikh, to kindly load her screen and take the first session forward. Thank you.
Shall I start, Srijan?
Yes, madam. Please share your screen and you can begin.
Yes, I already shared my screen. And is it visible to all of you?
Not yet, madam. Can you share it again?
Now, is it visible now?
Yes, not full screen yet. Perfect, madam.
Maybe to full screen actually. Okay. So thank you so much for giving me this opportunity. Thank you to Dr. Subramanieshwar Rao sir and all the seniors and Srijal for being in communication. I welcome Dr. Ramakrishna. I know him since so many years, and he's very good in as far as the cytoreductive surgery and HIPEC is concerned. And my two examinees are there. One is Pushpakala, another is Pratham. And I'll ask them one by one question by giving giving them names so they can both get an equal opportunity. So I'll start with my first case. And today's case, the first case is a 39 years old female patient with ECOG 0, otherwise a healthy lady. She's a mother of 2 kids and her weight is around 55 kg. Her abdominal hysterectomy was done. The histopathological examination was benign. And she presented 1 month back to some other doctor with intermittent lower abdominal pain. She was investigated there, and the CT scan was found to have a sigmoid mass, and CA level was 416 nanogram per ml. It was raised, and she went laparoscopic sigmoid colectomy to the other hospital, which is outside of our hospital, and they did a laparoscopic sigmoid colectomy and biopsy of omental peritoneal surfaces. And that histology was, she came with this presentation. I mean, she came after the surgery to us. It was moderately differentiated adenocarcinoma. It was T4N2M1 disease. Lymphovascular and perineal invasion was present. 4 out of 12 nodes were positive for metastasis. And there was a metastasis to omentum and peritoneal surface was there. Upon confirmation that it is a peritoneal surface malignancy of a colonic origin, she was referred to surgical oncology department for the further treatment. My question to Pratham is: this history is enough for you, or you want more? You want to ask more history to this patient?
More history, ma'am. Family history, I would like to know. For
Okay.
this.
Why you want to know the family history?
Because she is a young age, less than 45 years of old female with colon malignancy.
You want to what kind of a question you want to ask in relation to family history?
I would like to ask regarding the similar history of the similar malignancy or any HNPCC relevant malignancy like endometrial malignancy in her first degree relative like mother or siblings, or in grandmother like second degree relatives.
Okay, her hysterectomy was done, but it was an adenomyosis, so this is not relevant to this thing. Any other history you want to ask other than this family history? Any other etiological factors you see in a colorectal malignancy? To the other examine, I just forgot the name.
Examination point of
no, history point only. History point only.
Like Dr. Pratham told, I would also emphasize upon the family history in this patient. Other history would be, since it's a left-sided colonic cancer, history of irregular bowel habits, constipation, melena, but that does not come to the etiology point of view.
Okay.
I don't want to ask anything more.
Do you want to ask her whether, in her personal history, whether she is a vegetarian or non-vegetarian? Does it make any difference to this patient particularly?
Yes, because consumption of fat-rich food, red meat, are one of the risk factors for colorectal cancer.
Okay, that is good. Any other thing in the food history? Whether she is a vegetarian or non-vegetarian, does it make any difference to this particular case?
In sense of red meat and fat-rich food.
If I may interrupt Dr. Pushkala, I think he's asking a very pointed question, and she's also clue whether it is relevant here. See, you have to understand that this patient has come to you with an M1 disease with peritoneal. You think whether she's a vegetarian or non-vegetarian going to make any difference in the management of this patient or her outcome? So the question, I think, is pertaining to this particular patient, this situation. What are you going to do? What are you going to ask them? you mentioned family history. All right. Although it may not be directly relevant to this patient, it could probably be relevant to her relatives in case she is part of some family. That I can understand. Any other questions you would like to ask this patient? He's undergone a surgery recently.
History of excessive menorrhagia or polymenorrhea history previous
He's
to
already had a hysterectomy, is it?
She had a hysterectomy for adenomyosis. For that, she had almost bleeding for 1 year, but that histopathological examination was benign. So I think the abdominal, the hysterectomy part is not coming in way, particularly for this case actually.
I think we can move on to the subsequent slides.
Okay. Okay. So I wanted to ask whether she's a vegetarian or not non-vegetarian, whether because the red in processed meat is one of the etiological factor for having a colorectal malignancy. Second is the personal history of smoking, although she is a female, but that doesn't deny that she may not be a smoker. Third is alcohol consumption. The lack of physical activity, and she's young. She's already having 2 kids, but the fertility history is also important if she would have been more younger, but not particularly for this patient. So these are the few things which is left for the history. So now I move on to the second slide. Is the histology was moderately differentiated adenocarcinoma, and LV, lymphovascular invasion, peritoneal invasion was present. 4 out of 12 nodes were positive, and the metastasis to omentum and peritoneal surface was positive. So now she referred to higher center because this is peritoneal metastasis of a colonic origin. So that was, she was evaluated further also in terms of routine blood investigation and tumor marker also. So now her CA level is 300 nanogram per ml, and her estimated peritoneal cancer index by CT scan is, looking to the disease and all, it is around 13. There is no significant family history, otherwise there is no disease elsewhere. So in investigation, which, what else you want to, these are the investigations are enough, or any other investigation you want to advise to this patient, to Pushpakala?
Yes, ma'am. I would like to add additional tumor marker of CA19-9 because CA9 compared with the other markers, CA125 does not correlate well with the recurrence or in the setting of peritoneal metastasis. But CA19-9 can be used to monitor the post-operative course of the patient and keep her in the surveillance. In addition to the CEA, also since I have the biopsy, I would like to perform a IHC MMR on the biopsy. IHC for mismatch repair deficiency syndrome, and CT or HRCT of the chest I would like to do. Or since the CEA is more than 300, is more than 100, 300 is 300. If the patient's logistics permit, I would, even though it is a lesser down the ladder, but I would also like to have a PET scan because the CEA is more than 100. Because I want to be sure that there are no other metastases. And the PCI is there on the CT. Or if the logistics doesn't permit, HRCT of the chest would be fine. And since she's recently operated, I would like to reserve my full-length colonoscopy for a later date within 6 months of further management of the patient.
So, Dr. Pushkala, I have 2 questions for you.
Yes, sir.
One, you said you will ask for IHC for mismatch repair.
Yes, sir.
Why do you want to do that?
NCCN recommends universal testing of IHC MMR as a part of screening for Lynch syndrome or for all patients with colorectal cancer, particularly in this patient because she is of young age.
I would like to remind you that you are looking at a patient with M1 disease with peritoneal metastasis. So,
yes, sir.
I agree that universal MMR testing is recommended by NCCN and some other societies, not widely practiced. But in this particular patient, why do you want to do IHC?
Yes, sir. Because
and are there any other similar things that you would like to do?
Yes, sir. I would start with doing an IHC MMR because if she is a deficient MMR, then I would like to target, give her options further down the line of treatment to immunotherapy as it's a immunogenic tumor. could be. And proficient IHC MMR means like I would, and again, if the IHC MMR in that, if there is a loss of nuclear expression of MLH1, it adds to, I will do a second step in the testing BRAF mutation to rule out the somatic hypermethylation of the MLH1 promoter region. Or if that is also negative, then I would like to do a germline mutation testing for this patient. One thing in IHC MMR, it could be used for a tumor agnostic therapy, first thing. Second is like to also prognosticate the patient. And thirdly, for germline testing.
How will you prognosticate the patient based on your match repair status? I can understand you said about hiding germline mutation and also using immunotherapy. The third point you said about prognosis, how is that? How are you going to do that based on the?
Yes, sir. Usually the IHC MMR proficient tumor IHC MMR in not this patient but in stage 2 IHC.
So please understand
yes,
the same thing to both the residents. Please answer relevant to this particular patient. Right?
Yes.
You are right when you said may help in prognosis. But how? Is MMR status alone enough for you to prognosticate a patient with colorectal cancer? Or would you want to do something?
RAS testing, KRAS and testing I would like to do. If there is a wild type KRAS, then other further applications, further tumor agnostic therapies in the form of cetuximab can be given.
Don't deviate from the question. We are talking about prognostication, not guiding therapy.
In this stage.
So tell me, generally, a patient with an M1 colorectal cancer, you send to the medical oncologist, they ask for a panel of tests, including next generation sequencing. So what specific things would you be interested in, both for prognosis as well as for therapy? The NGS panel. Can you name some common things that you would be looking?
In the NGS panel, I would like to see what is the gene mutated so that the same specific gene can be tested in her first degree relatives.
No. I'm not talking about family history. I'm not talking about hereditary cancers. I'm talking about therapy and prognosis.
Yes.
So,
RAS mutations.
Just an advice to all the residents, please listen carefully to the question that is being asked and answer relevant to that question. So, I mean, sure, this is something that you commonly see the medical oncologist asking for and planning therapy based on results. And you yourself have mentioned some of these. Dr. Pratham, would you like to add to what Dr. Pushkala has already said?
In NGS panel, we can also look for P53 mutation, Ki67.
But what are the other more relevant and important things that something that can be targeted?
HER2 expression in case it is.
Would you not look at KRAS, NRAS, BRAF,
yes,
all these before you look at E53 and HER2, Ki67? Ki67, you don't need an NG.
After these, sir. First,
are you aware of any combinations of these markers that will help prognosticate a patient with peritoneal metastasis in colon? Yes or no? Pratham?
Combination of BRAF, we have to combine. Yeah. We have to combine BRAF in case we get MLH1 positive, sir, to see whether it is a sporadic form or.
No, again, you're deviating off the topic. Not talking about germline mutation. Please leave that aside. I'm talking about this patient, metastatic colorectal cancer, peritoneal metastasis, prognostication based on molecular marker. All right, fine. I will be touching upon that. But BRAF generally has got a poor prognosis in colorectal peritoneal. But patient with BRAF mutated with an MSI high has a much better prognosis than any of the other forms. This is just one fact that you need to keep in mind while choosing patients for treatment. Right? So, Dr. Pushla, the second question I wanted to ask you is, you said you will put a PET scan down the line. Why do you want to put it down the line?
Because the patient already has a CT with, which shows the PCI index, and also I can discuss with the outside surgeon who had done the surgery to get the PCI score.
Why are you interested in knowing the PCI?
Because I would like to go know the PCI, because if the PCI is more than 20, there is a high chance that the patient will not be operable, operable upfront, or I will not be able to achieve a CC0 or CC1 for the
If
patient.
it is less than 20?
If it is less than 20, then again, the best chances for the patients are if it is less than between 10 to 15.
So here,
or,
you know, it has been mentioned the PCI here is 13. Okay.
Yes.
So is that sufficient for you to decide that you're going to do CRS?
Yeah, I would also like to find out which are the regions and what are the scores per se. The PCI chart, availability of the PCI chart would be better. Yeah.
I'm talking with respect to doing a PET scan. Why do you want to put a PET scan down the line?
Because there are only.
Why do you want to do a PET scan? Tell me that.
Yes, sir. Because only reason is the CE is more than 300. I would. One thing is I would not like to do a non-therapeutic.
If the CEA were just say 25, would you have asked for a PET scan?
Not likely, sir. HRCT chest and the CCT abdomen pelvis, I would be happy.
You did not say HRCT chest.
I had told
that is why I asked you. So you need to rule out other sites of metastasis, isn't it?
Yes, sir. Yes, sir.
So if you're not doing a HRCT chest, you could ask for a PET scan. That would be, yes. I would rank it as one of the first investigations I would do if I feel that this patient is a potential candidate for a curative intent. Right?
Yes, sir.
Can we move on now?
Yes, sir. Pushpakala, once you say that you are going to do a HRCT thorax, and then why there is a need of what exactly you want to know by doing just an HRCT thorax?
Presence of any lung metastasis.
Okay, so you want to see an extra-abdominal metastasis?
Yes, extra.
Yes, yes. So this is the, extra-abdominal metastasis will actually rule out whether you can offer a patient this radical surgery or not. So the point is very valid if it is normal. If it is normal, is there any necessity of doing a PET CT scan?
Not likely, ma'am. In the literature, there has been multiple evidences, like one of which is in a meta-analysis, which say that in a patient whom we are planning for a potentially curative treatment in the form of CRS hypecductu in this M1 disease, almost 80% of the time, PET CT is known to upstage around 18% of patients with already a metastatic cancer. So in that way, we can avoid a number of non-therapeutic laparotomies. So that is why.
Okay.
Dr. Pratham, how confident are you with the CT PCI of 13? Do you think that would be an accurate assessment of the PCI score?
No, sir. CT is not always able to pick all the smaller diseases, sir. So we to further to see actual PCI, we need to do a diagnostic laparoscopy. But at this point of time, since it is only 1 month, I would not like to proceed with diagnostic lab per se now.
So what do you think is the discordance between the actual PCI score that you find on laparotomy and the PCI score on a CT scan? By how many points do you think they will be different? If by too many points or just a few points? The score, right? Here the CT PCI is 13. You expect the actual PCI score to be 25?
Variation should not be that high, sir, if we are able to catch the disease on CT scan. If we are not able to catch the disease on CT scan, we might find disease on laparoscopy. In that case, variation might be higher. But since CT is able to catch the disease, the difference should be less only, sir.
All right. We can move on.
So I think majority of time when patient present to us, they come with this CT scan, and now we have to decide which other investigation we want to go. Is there any difference between by doing a CT abdomen and pelvis or by doing an MRI in case of peritoneal carcinoma metastasis? If you given a choice, which one is better for you or which one you prefer to do it? Pratham, your answer?
In case we are suspecting the location of the peritoneal carcinomatosis in difficult regions, MRI would give better picture of infiltration of that area, like in root of mesentery or portal region or little pelvic walls.
Okay. Even the smaller size lesion can also be better accessed with the MRI as compared to CT scan. What is your take on that, Dr. Ramkrishnan?
There is a lot of literature coming up nowadays on the diffusion weighted MRI
Yes.
in peritoneal metastasis. But it is highly dependent on the person who is reading the scans. You need a lot of expertise for that. I can't make head or tail of peritoneal metastasis on MRI, to be frank. So I would rather rely on the CT scan, understanding that it may underestimate the actual piece.
Okay. So routinely at your center, CT scan, abdomen and pelvis is the investigation of choice in case of peritoneal carcinoma metastasis?
As of now, yes, because we still don't have the expertise read properly MRI of the peritoneum.
Okay. Is there any, what about this fibroblast associated PET CT scan, which is a new coming and experimental? Does anybody has used it or it is still in
Yeah, we have used it in some few patients, especially mucinous or signatory cell tumors.
Yes, perfect.
In one patient where I had the opportunity to FDG PET and FAPI, I found FAPI picked up some lesions that were not picked up on the other. But I have not much of experience on FAPI scans. Do you know what FAPI scan stands for? What is how is this
associated with PET CT scan, where the agent is used is different. Okay, sorry.
Dr. Pushkala, how is it different from the PET scan, other than the fact that the agent used? Are you aware?
FAPI PET uses gallium-68 fibrogen activated protein. This protein, it is mostly useful in tumors which are desmoplastic like breast, colon. In this kind of tumors, what happens is there is the collagen usually which expresses
just give me a very short, simple one sentence.
Yes, sir. The tumor cells.
What is one important difference between
FAPI? It's endo and exonuclease. And
Dr. Pratham, do you know?
No, sir. Sorry, sir.
So, PET scan, the FDG PET scan, what does it pick up?
Areas of metabolic uptake.
In the
tumor as
the
well
tumor.
as in
Whereas what does FAPI pick up?
Metastatic regions, the collagen with the altered.
Within the tumor cells, or is it in the stroma?
In the stroma.
The stroma, because the fibroblast associated proteins are expressed in the stroma. That is the important difference between the two. PET scan picks up the cancer cells, whereas FAPI looks at the stroma. So it is supposed to be even more specific, because the other false positive that happens in a FDG PET usually are not seen with FAPI. All right, so I think let us move on to the management. I think that's more interesting.
So we already discussed about the diagnostic laparoscopy. Is there any issues with the diagnostic laparoscopy in accessing the PCI score? To Pushpakala?
Yes, ma'am. In the diagnostic laparoscopy, we can essentially assess the we cannot assess the whole length of the small bowel. The 0 to 9 regions are could be assessed, but deep in the pelvis, in case of an obese patient or falling bowel, it's difficult, and we need an extended D-lap to mobilize a small. I mean, to lay open the small bowel and see the mesenteric areas, both the mesenteric and in the both sides of the mesenteric have to be seen. So it is quite difficult on a D-lab to completely give us a picture of all the 13 regions of the thing, especially for the small bowel regions and pelvis sometimes.
Oh, I'm sorry, I think you got it wrong. D-lab is a very good tool to assess small bowel disease. It is right in front of you. All you need to do is walk through the small bowel. That is the terminology used. Walk through the small bowel from the BJ flexure to the ileocecal junction. You can very well see the entire small bowel mesentery and the serosa. That is not the blind spot for D-lab. There are some blind spots, especially the retrohepatic area. There are additions there with the diaphragm. Inside the lesser sac, unless you do an extended lap, you open into the lesser sac. The other blind areas are in that triangle between the inferior vena cava, caudate lobe, and the right crus of the diaphragm. These are the difficult or blind spots in the small bowel. For proper D-lap, you should be able to visualize this, unless, of course, there are additions.
So one of the difficulty with the diagnostic laparoscopy is there is a difficulty in positioning trocar if it is a totally abdominal disease is there. So you might puncture it, and the contamination of portal site is port site is also one of the difficulties there. Otherwise, you can very well access if your diagnostic laparoscopy is given as a choice for this PCI scoring. So I've got only 2 CT images, so please pardon with this. And this patient already have a ovaries, but the hysterectomy was done, and the disease was mainly into the left lumbar region, the umbilical area, and exit into center into the pelvic area. The left side of the lower pelvis area was free. Right subhepatic and left subhepatic areas were free of disease. Even the right side of paracolic gutters are also free. So this is what it is, the PCI, I mean, the CT abdomen picture of this patient. We have gone for the CT scan thorax also, that is, they're not showing any extra abdominal disease. So the question is, what exactly the management options? Shall we go for the palliative care, systemic chemotherapy alone? Any aggressive multimodality treatment with a curative intent, like cytoreductive surgery with HIPEC, which is followed by the systemic chemotherapy, or we can go for the NACT followed by CRS with HIPEC, followed by the adjuvant treatment. So come to Pratham. Pratham, will you want to take this question?
Yes, ma'am. Since the patient is a young age, fit lady, along with no metastatic disease anywhere else, I would like to first go for a neoadjuvant chemotherapy for her. And I would like to restage the disease after 3 months of therapy. Then if it is not progressing, then I would go to look for CRS and HIPEC feasibility. If CC0 is feasible, I would go proceed with the cytoreductive surgery and give HIPEC, and then further followed by adjuvant therapy later on.
Okay, why not the neoadjuvant chemotherapy followed by cytoreductive surgery?
I think that's what he said. He would plan for neoadjuvant chemotherapy.
Okay.
So, Dr. Pratham, can I ask you a question?
Sir.
Is this information sufficient for you to take? Or do you want to do something else? The patient is sitting in front of you, in all these reports. Do you want to get any more information or
colonoscopy? I would like before proceeding to surgery, I would like to do colonoscopy to look for any synchronous primary left into the colon, so that to plan further resection if required.
Okay. I wouldn't say you're wrong, but I don't think that's so very relevant at the moment. Anything else? Dr. Pushkala, imagine you're in the OP, this patient is there in front of you. What do you normally do? Patient has had a surgery outside and has come. Any of you?
Slide review, sir, in tertiary.
Oh,
setting.
yes, you would want to do a slide review. Why
And
do you
I-
want to do a slide review other than just confirming whether it's a carcinoma or not?
To see the histologic subtype and the grade, sir. In case it
You are dealing with a young patient with a peritoneal metastasis. You want to make sure it is not a signet-ring cell carcinoma.
Yes, sir.
Would that change your decision if it is a signet-ring cell?
Yes, sir. I would be reluctant to do. I would be reluctant to plan a CRS HIPEC in that
Would
case.
be reluctant. I think you worded it very well. You would be reluctant. So you're not completely ruled out, but you said you're reluctant. That is correct. Generally, signet-ring cell cancers do quite poorly, especially in India,
Yes, sir.
with metastatic disease. ECI is indeed very low. Still think of. So I like your answer. You said you're reluctant. Anything else, Dr. Pushkala? Are you with us?
Yes, sir. Yes, sir.
Yeah. So anything else you would want to know? Patient has been operated outside and has come to you. Giving you a clue.
Yeah, I would like to speak to the outside surgeon about the findings.
Exactly.
intraoperatively.
Speak to the outside surgeon for what?
What exactly was his PCI score, whether he has recorded it, what was his intraoperative findings, what was the what was the
What
status
specific
of the
questions would you ask?
Yes, sir. So I would ask him to give me a return PCI score status of the omentum, where all the deposits were there, and proper scoring, which I would be needing. And secondly,
So one is the score, the total score you're interested in.
Yes, sir.
Are you interested in the distribution?
Yes, sir. Distribution with
Why?
all. For this patient, I would like to do aggressive multimodality therapy with curative intent.
No. Distribution meaning where all in the peritoneal cavity the disease is.
Yes, sir.
Are you interested in knowing that?
Yes, sir.
Why?
Because if there is
suppose you have two patients. One patient, the PCI score of 13, but the disease is exclusively in the right and left subdiaphragmatic peritoneum, the parietal, the anterior abdominal wall peritoneum, pelvic peritoneum. You have another patient with the same PCI score of 13, with most of the disease confined to the small bowel EC.
Yes, sir. Because
both have the same PCI score. Do you think there will be a difference in the outcome and your ability to cytoreduce between these?
Yes, sir. In the first scenario, I would be able to cytoreduce because I would be able to do a peritonectomy, subdiaphragmatic peritonectomy, pelvic peritonectomy, parietal wall peritonectomy, complete peritonectomy can be done. In the second scenario, in the small bowel deposits, I would like to assess what is the length of the small bowel, whether it can be achieved, whether the cytoreduction can be achieved by a mesenteric stripping or there is a resection anastomosis of the small bowel needed. What is the length of the small bowel I would like to sacrifice, and if it is too much, then I would be like.
So are you only looking at whether you will be able to cytoreduce or not? So what if I say I will be able to cytoreduce? You still think I should go ahead with surgery in the second patient? What does that tell you about the biology of this? Mesenteric deposits versus parietal peritoneal deposits. Which behaves better?
Parietal.
So all these things you need to have information and you need to keep in mind before planning for therapy. So it is very important in a patient who has been operated outside and come with peritoneal metastasis. You need to know all these details before even thinking of deciding on what treatment you are offering. All right, so review the outside slides, speak to the surgeon, or at least write a letter to him and get all these details. All right, only after this you will be able to plan. But before planning any of this, there is something else you should do. That is the difference between a surgical oncologist and a general surgeon. Remember, you have to treat the patient as a whole.
Yes, sir. I would,
Dr. Pratham, anything else you would want to speak to the patient about before starting any treatment?
I would speak about the post-operative morbidity, and also I would be removing the bilateral ovaries. So I would like.
No, see, you have don't decide that you are going to do only same, right? May not be just relevant to this patient. Any patient who comes to you with metastatic disease, especially peritoneal metastasis.
Performance status, I would like to see this.
No, not
Nutrition.
what you see, it's what you do, the patient and the relatives. This is something that as a surgical oncologist, you should do all your patients and their family members. And it is called discussing the goals of care. Right? Remember, peritoneal metastasis is not a very, even though you may be doing CRS and HIPEC, doesn't mean that the patient is going to get cured. Patient may have relapse. Patient may have a lot of distressing symptoms because of the peritoneal disease. Patient may lapse. He may go downhill. You need to have a wholesome discussion about what to expect with the patient. Just discussing the goals of care is a very important part of treatment, especially in patients with metastatic disease, especially peritoneal. Don't discuss all these things in advance. After completing treatment, suddenly one day the patient might come in a sick state. Somebody might admit the patient in the ICU and put the patient on a ventilator. It is not a kind thing to the patient with a terminal stage 4 cancer to be put in the ICU on a ventilator. So you have already had this discussion with the patient clearly tells you, I don't want to go to ICU later, then you are preventing event from happening. Remember, these are all quality indicators. You're putting a patient with peritoneal disease with metastatic the ICU in the last few days of it. Right? So all of you must remember to have a good, proper discussion regarding all the possibilities and eventualities that happen when you start. Right. Now coming to the actual management option. Suppose this patient had come to you. You have done anything different. Do you think what the surgery that was done outside, was that a correct thing to do? Dr. Pushkala.
Yes, sir. When the patient, if she had come to me in the first place, based on her CEA and the CT scan, which is already showing a peritoneal metastasis, I would like to further evaluate the patient and plan her, not only plan her, I could do it in 2 ways. One is I could offer her a stenting, then resuscitate. In that way, patient's obstruction may be relieved. And then as a second stage, I would go inside for a definitive surgery, which will entail a cytoreduction with HIPEC. So that one thing.
So what I'm trying to say is, you don't know this patient has got peritoneal disease. The surgeon who operated outside also didn't realize until he opened up. Having opened up and finding that the patient has got peritoneal disease with stage 4 of A13, do you think it is a good decision to just remove the primary tumor and then refer the patient to you for further therapy? What would you have done? You had opened the patient and found that the patient had peritoneal.
Yes, sir.
This is called an incidental detection of peritoneal metastasis.
Yes, sir. First thing, after I would properly assess the PCI score and consult my colleagues if it is possible to do a complete cytoreduction now with a HIPEC on table, and with also the permission of the attendants. Attendants will also need to be prognosticated that what we saw after opening is not what we expected to see. So it's a stage 4 disease, but still she will have the best possible chance now if we are able to do a complete cytoreduction and HIPEC. I would like
but
to
you
get
have not got the consent of the patient.
Yes, sir. I have not got. In that case, I would close the abdomen and plan for a second surgery. In that, but she's obstructed, subacute this obstruction is there.
She's having partial obstruction.
Partial. Oh, yes, sir. I can close. But close the abdomen and plan a proper surgery after the consent of the patient in a second setting.
Right. Dr. Pratham, any other option? Would you have done anything differently? Or is there any other way of managing such a patient?
Sir, considering it as an impending obstruction while preparing the patient, I would like to do the diversion first and close and then resuscitate the patient. And as you told, will counsel and discuss with attenders as well as patients, and would like to preoperative nutrition therapy as well as respiratory incentive therapy I would like to start, and then I would like to proceed with my treatment, sir.
So you would like to do a diversion stoma to relieve the impending obstruction and then proceed with treatment. So what treatment would you plan? Would you, like you said initially, would you give neoadjuvant chemotherapy and then reopen the patient, or would you just reopen the patient after having a discussion?
I would, if it is, if it is the distribution wise, it is operable, sir. I would like to go with the surgery first, sir. See, if CC0 is feasible, I would go with the CC0 HIPEC. Then I will plan for adjuvant chemotherapy in this way.
Why do you want to do that? What is tilting your decision towards surgery first rather than neoadjuvant chemotherapy?
So complete removal is the only option to improve her cure rates or increase the survival of the patient. I would not want to.
Correct, but you can do this complete removal even after neoadjuvant chemotherapy.
Sir, peritoneal mets are not responsive to systemic chemotherapy very well, sir.
All right. So what is your fear?
So it might progress and become metastatic or locally aggressive, and I might not be able to give the cure. So that's why this is the best time to.
So you think that if you give neoadjuvant chemotherapy, this patient is likely to
proceed, sir.
Do you know is there any rates of disease progression that has been quoted in the literature on disease progression on neoadjuvant chemotherapy for peritoneal metastasis?
I'm not sure about the exact numbers.
Want to take a guess? All right. Dr. Pushkala, are you aware of what is the likelihood of progression of the peritoneal disease on systemic chemo?
40%. Yes.
Are either of you aware of any ongoing trial which is looking at this question? Neoadjuvant or perioperative chemotherapy versus surgery first? Peritoneal metastasis. Can you name the trial? Pardon?
Yeah, the group of trials are CARO trials. I'm just taking a guess. Till now, there are no randomized control trials.
None published.
Yes.
But one has published its short-term results. You're right, Cairo.
I don't know the numbers. CARO trial, but the number.
Cairo 6. Okay.
Yes.
So in that trial, the rate of progression while on systemic chemotherapy in the neoadjuvant arm was quite low. I think around 5% or 8%. So yes, that is a genuine concern, but apparently it is not so high as to deny a patient neoadjuvant chemotherapy. But yes, you could operate on the patient first. There are advantages and there are some disadvantages. Now, suppose you don't have the expertise to do CRS HIPEC and you come across such a situation and you don't want to proceed further, you want to refer the patient to a center which does CRS and HIPEC. What information would you give when you send the patient to that center? Dr. Pratham.
The distribution of the disease, PCI score, and histology of the disease, and grade of the disease that I would like to.
Now you have seen the CT scan of this patient. Seeing that CT scan, do you have any concerns regarding the prognosis or the operability?
She has a bulky disease in the lateral pelvic wall region, pelvic region, sir. So
What is
that
the first thing that strikes you when you see the CT scan? Bhavna, is it possible to go back to the CT slide? Yeah. Look at the image on the left with the 4 arrows, that image. What is the first thing that strikes you?
Ascites is there.
Pardon?
She has ascites.
Ascites, very good. Why is that of concern? Is it a good sign or a bad sign?
Bad signs.
So ascites, patients with peritoneal disease, colorectal cancer with ascites, prognosis usually is. The ascites usually doesn't resolve, may sometimes resolve, but even then, results of CRS HIPEC are not good. Presence of. So that would be a very important thing that you need to look for that the patient has ascites. All right. Can we move on? Next slide.
So now I'll come to some of the questions to both of them. First to the Pushpakala. What is the incidence of colorectal peritoneal metastasis?
Yes, ma'am. They can be answered into parts. One is in primary setting.
Dr. Bhavana, if you don't mind, I think I'll be answering some of these.
Okay.
So do you think we should proceed to the next case capsule that you have? We have probably around 10 minutes left.
Okay,
If I'm not mistaken.
I'll be skipping all this. I think you are going to speak on this.
Yeah, I think we can skip this, I think.
Can we skip this slide also?
Yeah, I think I'll be dealing with these.
Okay.
Yeah, I think we can skip all.
So
quickly we'll go through this.
okay. So move on to the second case. She is again a 55 years old female patient with a history of a hypertension. She is on a treatment and the hypertension is well controlled. ECOG 0, and she is operated for the sigmoid colectomy 2 years back. And there was a bleeding PR on and off, constipation since last 3 months, anorexia, blood transfusion was given for anemia. She is otherwise vitally stable, no fever, no jaundice, no edema, no lymphadenopathy. Her abdomen was soft, no tenderness, no lump, no organomegaly, and there is no ascites. Histologically, this previous surgery, it is moderately differentiated adenocarcinoma T3N0, 0/18 nodes positive, no LVI, no PNI, and there is no tumor deposits also. And her MSH and MSH8 is 2 and 8, both expression was 0. Adjuvant treatment was not given. She was kept on observation. And after 2 years, her CA was rising, but there was no abnormality detected. So any other things you want to ask? I think I've covered this question in the previous slide. So I'm just keeping this, this slide also. In examination on digital rectal examination, the mass was felt at the tip of finger. Pervaginal examination was normally made. What else you want to see in the digital rectal examination? And do you go for the stool for occult bulb examination during a routine part of your practice? And what about the proctoscopy finding? I mean, you do proctoscopy, and what things you are expecting in the proctoscopy examination? To Pushpakala first.
Yes, ma'am. If it were an upper or mid-rectal tumor, I would have felt the anastomotic line here, but I'm not sure whether I'll be able to feel the anastomotic line here in the DRE. I would not like to do a stool occult blood examination because it's not going to give me any extra information. Rather than proctoscopy, I would like to do a full-length colonoscopy for her. Because CEA is rising, there is no evidence of disease, whether in general clinical examination. So I would like to do a full-length colonoscopy.
Okay, not the flexible or rigid sigmoidoscopy also. Why not? Or you want to go for the full colonoscopy?
Most of the time, the metachronous cancers happen within first 2 years of treatment, and they are little higher in the first 5 years, according to all the data available. So I would like to rule out first a a metachronous cancer. For that, and she would also be. I mean, instead of a proctoscopy, I feel that a full-length colonoscopy will give you more information regarding metachronous cancers or adenomas, polyps, or.
So you will go for the full colonoscopy? Okay.
Yes.
Okay, thank you. So we have undergone the blood investigation. Her complete blood investigation, chemistry profile was within a normal limit. She was anemic, so for that the blood transfusion was given. Is there any relevance of blood transfusion in case of a rectal cancer? One should, I mean, what is impact of blood transfusion on colorectal malignancies?
In rectal cancer, blood transfusion was known in some retrospective studies. There were patients who received blood transfusion they had poor survival when compared to patients who did not receive, but I don't think it has been proven by any other randomized controlled trials or anything. So right now, blood transfusion, I wouldn't link it to any poor outcome in a patient with rectal cancer.
Okay, so will you give a blood transfusion or not give it? The patient comes with a hemoglobin of 8. So you give blood transfusion pre-operatively?
For 8, I would like to wait.
Okay. So what about you?
Sir?
So Dr. Pratham, this patient has an increase in the CEA.
Yes, sir.
What are you going to do first?
As Dr. Pushkala said, I would like to do first colonoscopy, and then I will look whether it is a metastatic disease or a local recurrence. Sir.
So you have already assumed that this patient is what?
Since mass is felt at the
Suppose mass was not felt on it.
Then
there will be a rising CEA.
Then I will see whether it is biochemical recurrence only, where disease is not visible on.
I'm unable to hear you.
Sir, I will in case only CEA is. Hello, am I audible, sir?
Yeah. Please go on.
Sir, I will see whether it is only biochemical. If only CEA is rising, I would like to do the metastatic whole body workup and see if there is any visible disease or not. Accordingly, I will plan my management, sir.
Would you give any other option to the patient?
We can see the trends of CEA. We can repeat a CEA after
3 months.
Why do you want to do that? Why do you want to do that?
Because 50% of the time, sir, CEA raised in post-operative setting can be false positive also.
Correct. So you can have a false positive elevation of CEA, which is not uncommon.
Yes, sir.
So it would not be wise to suddenly jump and ask for a whole battery of tests.
Yes, sir.
Just because one reading of CEA is. What is the half-life of CEA?
5 days.
When would you want to repeat a CEA?
3 months later.
3 months later.
3 half-lives later.
Normally, what is the dictum? After how many half-lives will you?
Minimum
3 half-lives.
Minimum 3 half-lives.
So 4 half-lives. So roughly about a month later, you can repeat the CEA and see if it is still on a rising trend or whether it has come down.
So the half-life is around 3 to 5 days, and if you wish to repeat it, you can repeat after 2 weeks to 1 month after the first testing.
So always keep that in mind. Just one value of raised CEA doesn't always mean that the patient is not a recurrent. You discuss the options with the patient. Don't just say, I will always repeat. Patient is very anxious, and if the patient wants to know whether there is disease or not, and she is not willing to wait that long, then it is fine to go ahead with the investigation, provided she is aware that it may be a false positive. Is willing to wait for a month, then wait for a month, then repeat the CEA. If it's still high, then you can ask for all these investigations. How often do you do a CEA on follow-up, Dr. Pratham?
Initially, sir, for first 2 years, 3 to 6 monthly is advisable, sir. After that, 6 monthly till 5 years, and then we can. ESCO guideline says that post 5 years of surveillance, we don't need to do regular CEA or any scanning unless the patient is symptomatic.
What are the other follow-up investigations?
If preoperatively colonoscopy was not achievable, then I would like to do one scopy after 6 months of the surgery, and then repeat after. If everything is okay, I will repeat it 3 years once, and then change to 5-year colonoscopy, sir, and annual CT scans for first 5 years.
So do you think there is any benefit in doing such intensive follow-up?
In colorectal cancer, in some studies it was found, sir, aggressive proactive approach is able to catch the disease in local as a local recurrence or still resectable metastatic disease like colorectal liver metastasis. So it is advisable, sir, because in that case, if we are able to achieve complete cytoreduction or complete resection is feasible, 5 years overall survival is improved to 35 to 50%.
Are you aware of any recent studies that have said just the opposite? That intensive follow-up does not improve overall survival or disease-specific survival?
Sorry, sir.
Dr. Pushkala, are you aware?
Yes, sir. CEA PAL, CEA Watch are some randomized control trials where these aggressive post-treatment surveillance or post-treatment surveillance of colorectal cancer was not found to be with an overall survival benefit. But we cannot debate to the fact that any rise in CEA can be picking up an asymptomatic recurrence. So we will be able to treat it completely. So just these studies, I would not go by these studies. I would still go with an aggressive post-treatment surveillance.
What is the first dictum before you advise the patient such an aggressive? You have read the IASO guidelines. What do they say in the beginning? Which patients would you offer aggressive surgery?
Stage 2, stage 3. Stage 1 may not need such an.
All right. All patients with stage 2, stage 3?
Performance status and age of the patient, I would like to see.
An 80-year-old patient with diabetes, hypertension, ischemic heart
Cannot.
disease, ES2, is just barely got through his right hemicolectomy. Do you
There is-
advise aggressive surveillance?
No, sir.
Patient has to be a candidate for some form of treatment if at all you detected recurrence. That is the first thing you must think of before advising aggressive.
Yes, sir.
Okay.
Yes.
We have just 2 more minutes left. Do you have any more slides?
Yeah, they just started. Shall I conclude this here?
Yeah. Yeah, I think I just quickly go through the next few slides and we can.
So next is about the
No,
investigation.
next one. So what was the actual finding for this patient?
Okay, so it was also proliferative lesion 7 centimeter above the inner extending up to almost 13 centimeter. The rest of the colonoscopy was normal up to the ileum. Biopsy was adenocarcinoma, moderately differentiated. And the questions for biomarkers and diagnostic laparoscopy or stenting to this candidate. Or shall we go ahead with the
So, Dr. Pushkala, do you think this patient can still be salvaged?
Yes, sir.
Provided her PET CT does not show any other site of disease. Do you think this patient can be salvaged?
Yes, sir. I think this patient can be salvaged. It's a local recurrence only. Local recurrence, I would go ahead and perform a low anterior resection, 7 to 13 centimeters. She can be salvaged.
Do you do anything else? Seven centimeters. This is a mid-rectal area. So
Okay.
one thing you're not sure whether it is an anastomotic recurrence or a second primary.
Second primary. Yes,
Which do you think is more likely?
second primary, but there are certain markers which I can get from the previous histopathology.
Within 2 years of primary surgery?
Like, I would like to go through the previous histopathology report thoroughly to see for any presence of PNI tumor deposits at the margins, there was any dysplasia or adenoma, or the previous full-length colonoscopy, whether there was any synchronous adenoma specific to this site which we are seeing right now. So if these are there, then I would tell it's probably except for the synchronous adenomas, it may be it may change into a metacronous cancers. But these high-risk features which are present on the histopath report of the previous surgery will tell that it could be a more possibility that it is an anastomotic recurrence.
Dr. Pratham, would you agree with Dr. Pushkala? Would you operate on this patient straight?
Post metastatic, if it is non-metastatic, sir, I would do the markers, sir. Since it is the disease has occurred at 2 years, so we can't say whether it is anastomotic recurrence or it is a second primary. So we don't know the biology of this tumor. I would like to see the biology of this tumor also.
What will you do? How will you treat this patient?
MRI pelvis with I would like to do an MRI pelvis for this patient because it's at
My question is simple. Would you give neoadjuvant radiation?
Yes, sir. I would.
That's what I want to do. Why do you want to give neoadjuvant?
Because previously the patient was patient did not receive any adjuvant therapy. So in this case, neoadjuvant chemoradiation would offer better local recurrence rate further down the line, and also it will improve the our circumferential margins would also be high chances it would come negative.
Dr. Pushkala, you said you would do an MRI. Doing an MRI change your decision to give radiation?
Yes, sir. If it is a mid-rectal growth, if it is a T2 or a T2 lesion, T1, T2 lesion, or early T3 with N1 or N0 without any extensive EMI, mid-rectal MRF is negative, not threatened, and I would like to go for an upfront surgery, because if my histopath report is T2 N0, I would not like to radiate this patient.
You would have been right if it were a primary rectal cancer in the middle third. Please remember, you're talking about a recurrent lesion.
Yeah.
Don't know why this patient has recurred. There might have been some lymphatic emboli. There might have been some mucosal spread, submucosal spread of the disease. You don't know. The recurrent lesion, I would probably prefer to give radiation before operating. Even if, because most intraluminal recurrences will not be very deep. It will probably be a T2 disease or even a T1 disease if it is detected early. And within 2 years, it is unlikely you're going to get a mid-rectal recurrence that is T3C, T3B or anything like that. I would probably tilt in favor of giving radiation. But that is my personal view. There might be others who differ from that. Dr. Bhavana, what do you say?
So, I mean, we have undergone MRI also, and that is suggestive of it is T3N1 tumor. There are two nodes are seen into one MRI image. The lesion is more into the center part, and there is a contrast in that is a lumen was there. So it was partially obstructing, not the completely obstructing. I would go for the upfront CT chemo radiation for this patient. I just want to ask the rest of the two people what is their answer. Pushpakala?
Yes, ma'am. I would like to, for this patient, I can make out the disease with the sagittal view only and not any month. But since it's a T3 lesion, I think I would be happy giving her short course radiation followed by delayed surgery and consolidation chemotherapy.
What about you, Pratham?
If the nodal disease is also there, I would like in the pelvic region, I would like to go with the long course concurrent chemo radiation first in this case.
Dr. Pushkala, again, remember, this is not a primary rectal cancer you're talking. There is very little evidence for short course radiation in the recurrence setting. You must always keep in mind these things, that this is not a primary cancer, it's a recurrent cancer, which is it's slightly differently primary. I think we have terribly run out of time.
Yes. I think I'll conclude here, and you can start with your talk.
Dr. Srijan, do we have time for some more?
Sir, we can take another 5 minutes if you want to conclude this case. After that, we'll move on to your expert talk.
Have any more slides, Dr. Bhavna?
Yes. So the question is around whether shall we go for the upfront surgery or NSCT or chemo radiation followed by the surgery?
Covered.
So this
Any more?
question regarding the radiotherapy, whether short course or long course, chemotherapy, any targeted therapy, how to evaluate this patient after chemo radiation on MRI, and is there any use of stenting or divertic colostomy before starting the chemo radiation?
Yeah, you could answer that question, Dr. Pushkalar. You want to place a stent in a partly obstructed tumor before starting radiation?
It's only partially obstructing, and I would clinically assess only the mass is clear to the tip of the finger. If the colonoscope is passed through, I would like to start the patient on long course CTRT. That
It's
will
not-
also shrink the tumor.
You're unable to pass your finger or the scope, having difficulty.
In that case,
You place a stent.
no, sir, I would prefer a diverting colostomy because
Why?
the patient also has an anastomosis, but 2 years it is there. I would prefer a diverting colostomy, sir.
Now, what is the reason you would prefer a divertist? Okay, Pratham, what would you prefer?
Since it is a rectal cancer, I'm not sure. Maybe the chances of stent displacement will be there in this case. And
Why?
also hypothetical,
Because it is a rectal cancer or because of something else?
because it is a rectal cancer, sir.
Because it's a rectal cancer, that doesn't mean the stent should displace. But you're right, there's a possibility of stent displacement here because
Tone might be lower because of previous surgery.
because you're going to give radiation. If the tumor is going to shrink after radiation, it's going to slip out. That is number one. Second, what are you planning to do for this patient after radiation?
Anterior resection, she may need
Pardon? Dr. Pushkala?
Yes, sir. I would like to do a low anterior resection, so she may have a stoma during that time also, as a diverting stoma would be needed during the radical surgery.
She's post RP, a low anterior resection, you will probably be considering a stoma anyway. And you put a stent in a tumor whose lower border is 7 centimeters from the anal verge. Stent will be sticking out below the tumor for another 3 to 4 centimeters. That's going to make your surgery even more difficult. It will cause more fibrosis, and it is going to make your surgery more. Okay, so you're right. Diverting stoma may be a better option in this than placing this.
So after completion of the chemo radiation, how long you wait for the surgery?
Dr. Pratham?
After long course RT, I would like to wait for around 6 to 8 weeks, sir. Based on the trial, Grecar trial, which has Grecar and Stockholm trial, which have considered the time of duration of treatment post CTR.
Stockholm trial was mostly for delayed surgery after short course surgery.
Yes, sir.
Not long course.
Yes, sir. It had 3 arms, in which one was long course RT, and
yeah. So let's skip that. Are you aware of any other recently published paper on time between completion of radiation and surgery?
Grecar 6, sir, they have compared 6 weeks versus 11 weeks, sir. 7 weeks versus 11 weeks.
They
And-
find any advantage in waiting for 11 weeks?
No, sir.
Is there any other
Well-
trial that has shown advantage of waiting for 12 weeks when compared to 6 weeks?
I've not heard any other
A
trials.
trial from the UK has been published as an abstract, as far as I know.
Okay.
It shows waiting for 12 weeks, logically complete. Anyways, so the current practice is to wait for at least 6 to 8 weeks before you plan surgery after radiation.
So this is a post-treatment scan, and there's a lesser residual lesion present in the middle rectum. Visceral fissure, which was previously involved, is free, and there is a good response to lymph node. Surgery was done in form of low anterior resection with stapler anastomosis. And the final histopathological report is mortality differentiated, adenocarcinoma T2N0, and all margins are clear. So what will be your next treatment? Pratham?
Adjuvant chemotherapy, I will plan for this patient. I would like to see MSI status of the patient and then plan.
All right. So
Deepala?
the situation is debatable whether this patient requires adjuvant chemotherapy. But I think probably we can have that discussion. Shall we conclude this case discussion then, unless anybody has anything else to add?
We'll conclude here. And thank you, Dr. Ramakrishna and Dr. Pushpakala and Dr. Pratham. It was a wonderful session, and thank you, Dr. Subramaniam sir and Srijal and all IASO seniors. I'll invite Dr. Ramakrishna to start his expert talk. Over to you, Dr. Ramakrishna. I'll stop sharing my screen.
Thank you, Dr.
Thank you.
Is slides visible?
Yes.
Big thanks to Team IASO Masterclass for asking me to be part of this very important session. So I've been asked to talk on colorectal peritoneal metastasis and locally recurrent colorectal cancer. How much justice I'll be able to do in 25 minutes, but so I am just going to talk briefly on the treatment, prevention, and palliation of peritoneal metastasis in cancer. A short note on whether intensive follow-up is required in colorectal cancer, and about local recurrence after radical surgery for a rectal cancer. So let's begin with colorectal peritoneal metastasis. All might be aware that it is a pressing problem after potentially curative treatment. Metachronous colorectal peritoneal metastasis can happen in around 40% of patients, and around 4 to 10% of patients might have synchronous colorectal peritoneal. But the good thing is, in nearly 25% of recurrent colorectal cancers, the disease is confined to the peritoneal cavity, thereby opening up an avenue for a potentially curative treatment. But again, downside is that nearly 30% of patients with colorectal cancer, cause of death is most often peritoneal. How do you diagnose peritoneal metastasis? We had talked earlier about incidentally detected peritoneal metastasis. Most often in the synchronous setting, peritoneal metastasis is diagnosed incidentally while the patient is undergoing a surgery, the primary tumor. And even now, almost 4 to 5% of patients with peritoneal surgery, there can be an incidental diagnosis of peritoneal. The patient who's already completed treatment and is on surveillance post-treatment, rising CEA, as was discussed in the last case scenario, especially with the negative PET scan, you should always raise a suspicion of peritoneal metastasis. This is something that we need to keep in mind when you pull out these all other parts of the body, you've done a colonoscopy, and everything is negative, the CA is still going up, that is when you should consider that the patient may have a peritoneal. We have already discussed the various modalities of diagnosis. Probably the golden standard as of now is still diagnostic laparoscopy. Can almost accurately determine the PCI and also get a biopsy confirmation of this. CT scan, it is not very good. The sensitivity is quite poor if the lesion size is less than 1 centimeters, and especially for tumors along the mesentery, small tumors, CT scan, the quite low. The FDG PET scan, again, because in small lesion sizes, the performance is poor and it does not perform well in mucinous tumors. Also talked about FAPI PET scan. It's still in an experimental stage. We have some encouraging reports. It is thought to be superior when compared to the FDG PET. And as I told you, it is based on the detection of reactive stroma, fibroblast activity stroma rather than the tumor cell. Among the imaging modalities, probably diffusion-weighted MRI has the highest sensitivity, but it requires a high level of expertise to interpret the scan. What can we expect in the future? Intraoperative fluorescent imaging using anti-CA monoclonal antibody is an upcoming area of research. It may help detect sites of disease which you would have otherwise missed on the naked. Coming to the evolution of treatment of peritoneal metastasis over the years and how the survival has improved. You all know that before the 1990s, survival was quite poor with a median survival of only around 6 months. And then as time progressed, survival improved with the introduction of cytoreductive surgery and HIPEC. It is now somewhere near 40 months in selected patients are able to undergo cytoreductive surgery with. So essentially, the treatment for colorectal peritoneal metastasis consists of 3 things: cytoreductive surgery, HIPEC, which is now being called into question, and systemic chemotherapy. Cytoreductive surgery ensures macroscopic cytoreduction, whereas HIPEC ensures microscopic cytoreduction, and systemic therapy treats other systemic micrometastases. The advantage of HIPEC is theoretically there's a dual advantage. One is of intracavitary application of chemo, which leads to intensification, whereby you achieve a very high concentration of the chemotherapeutic agent into the cavity. And as you all are aware, hyperthermia has both a direct as well as indirect cytotoxic effect. An added advantage is the large volume of perfusate that continuously washes out the peritoneal cavity, thereby moving the free intraperitoneal. But at the same time, there are a lot of variables in HIPEC. There is no real consensus on many of these things. Although I believe in the upcoming SOGI meeting in Venice, there is going to be some consensus statement on the techniques and the drugs for various malignancies. So the various variables includes what drug to choose, how will you dose the drug, and how will you administer? Is it a single dose or multiple dose? There's a fairly recent consensus on the temperature. It should be around 41 to 43 grade. Various perfusates are being used, including peritoneal dialysis solution. Dextrose is now not very commonly used of incidence of hypoglycemia during HIPEC, and also normalcy. Again, the perfusion rates, the perfusion volume, the time, all these varies. Also the technique, whether you do an open, closed, semi-open. There is nothing really available to choose between the technique. There is advantages and disadvantages of either an open or semi-open. Now, what is the ideal chemotherapeutic agent? Remember, you're giving HIPEC, you're exposing the cancer cells to the chemotherapeutic agent for a very short time, up to 90 minutes at the most. So the agent must be cell cycle non-specific. That is why if you wondered, 5-FU is a very commonly used drug in colorectal cancer. It is not, however, used for intraperitoneal therapy, HIPEC, because it is a cell cycle specific agent. We need something that is non-specific because the cells might be at different phases of their cell cycle. Need a cell cycle non-specific agent which is effective against that type of, does not require systemic or hepatic an active form. It has to be inactivated during the first pass metabolism through the liver, and it has to be cleared from the peritoneal cavity slowly. Must not have severe direct local toxicity. The current area of research is to identify personalized therapy. That is, identify which agent is best suited for that particular patient's tumor cell in the peritoneal cavity using organoids, which are called peritonoids because they are derived from the peritoneal metastasis. To do a diagnostic laparoscopy, take biopsies, make organoids out of that, and while the patient is receiving systemic chemotherapy, the waiting time, you can subject these organoids to various in vitro drugs. And the other future research that is happening now is using nanoparticles or hydrogel to deliver these drugs for better uptake by the. Does CRS HIPEC work? Unlike systemic therapy, which has, even with targeted therapy, the median survival time you can expect is around anywhere between 5 to 17 months. And remember, there is no randomized trial for systemic therapy exclusively in peritoneal metastasis. Whereas there have been randomized trials for CRS and HIPEC in peritoneal colorectal peritoneal metastasis. The earliest one was by the Dutch National Cancer Institute by Verwaal and his colleagues. In 2003, they showed that compared to only systemic therapy, CRS and HIPEC almost doubles the median survival. The long-term follow-up after 8 years was published in 2008, which they showed that after an R0 resection, the median survival is almost 40 months. And this is also supported by real-world data. We have large multi-center pooled data which shows that compared to just the standard of care, which was systemic chemotherapy, HIPEC has been shown to improve the overall. So from then, the question that was nagging everybody was, does actually HIPEC had anything to this whole treatment procedure? CRS alone sufficient, or should we add HIPEC along with CRS? So to address this question, the French group undertook a trial called the Prodigy 7, which all of you are familiar with. They published their data in 2018. However, it was a disappointment to most peritoneal surface enthusiasts. It was a multi-center randomized phase 3 trial where they compared only cytoreductive surgery with HIPEC. They did not show any improvement in overall survival when HIPEC was added, although they did not show any increased morbidity with the addition of. However, what they did show was that even with CRS alone, median survival was around 41 months. Not be thought of with using only systemic therapy. So this trial, although it was considered a negative trial, it showed that good cytoreductive surgery can improve the median survival of patients beyond 3 years. 5-year survival of almost 36%. The final conclusion of this trial was, first, there is an overall survival benefit absence by adding HIPEC. Only cytoreductive surgery should be the cornerstone of therapeutic strategies for colorectal peritoneal metastasis. Been a lot of debate post publication of this procedure, and a lot of flaws have been identified in this trial. The current thinking is that one of the main flaws was that they used neoadjuvant chemotherapy, which probably would have made the residual cancer cells resistant to the action of intraperitoneal chemotherapy. And they used oxaliplatin for 30 minutes, which from subsequent lab data has been shown that that is not the best way to deliver HIPEC. So now the trend is, has been changed to use of mitomycin for 60 to 90 minutes in colorectal peritoneal metastasis. Many centers are now very choosy about whom they offer HIPEC for, but cytoreductive surgery is here, no doubt about it. How do you choose a patient? Basically, you should ask 4 questions before choosing a patient for CRS and HIPEC. One, is the patient fit to undergo the procedure? 2 is the disease very extensive. You can get an estimate of this by looking at the PCI score. Third, can a complete cytoreduction be done? Because CRS and HIPEC is not going to be of benefit if you cannot achieve a complete cytoreduction, that is a CC. Even a CC1 is not acceptable as far as colorectal peritoneal metastasis. And finally, to have a favorable biology of the disease. This you look at by looking at the distribution of the disease, as I earlier mentioned, whether there was ascites, whether there was mesenteric disease, whether there is any extra abdominal metastasis, and also the molecular profile of the tumor. These things you need to look at before deciding offer a patient CRS with or without. This is a very old eligibility criteria that was published by the SOGI group to choose patients for colon cancer HIPEC. Good performance status, no evidence of extra abdominal disease. Can offer patients CRS HIPEC if they have up to 3 small resectable parenchymal hepatic metastases. There should be no evidence of biliary obstruction, ureteric obstruction, or more than one side intestine. No gross disease in the mesentery with several sites of partial obstruction. And if at all there is disease in the gastrohepatic ligament. To a great extent, this still holds good even more than 15 years after it was published. Now, to make things easy, a lot of nomograms and scoring systems have been published for choosing patients for CRS and HIPEC. Two of the more common ones are the COMPASS and the BioScope. The COMPASS looks at age, the PCI, the lymph node status, and whether it is a signature cell pathology or not. Whereas the BioScope also looks at the PCI and lymph node status, but differs from the COMPASS in that it looks at the grade of the tumor and also the molecular markers. So as I told you, BRAF mutation per se has a very poor prognosis, as in liver metastasis. Most surgeons do not perform liver metastatectomy if they are BRAF mutant. Similarly, there is a lot of data to show that the results of CRS HIPEC in the presence of BRAF mutation. So these are all combined to various scores, various categories. This is not very popular though, because some reason these are not used. Some of these data may not be available to us before writing on CRS. So we also discussed the patient who had an incidentally detected peritoneal metastasis and the various options of treatment. So I would put them as 3 important options that can be practiced. We are having a webinar by the peritoneal surface group next month, so we'll be discussing more during that. But to summarize, you could have 3 ways you could handle a situation when you come across an incidental peritoneal metastasis. One is an immediate definitive, where on table you can complete the cytoreductive surgery with or without a HIPEC. Another is an early definitive, which Dr. Pratham had opted for, that he would trauma or a bypass, especially in an emergency situation if required, take a biopsy, and then reopen the patient or refer for an early CRS HIPEC after discussing these options and the pros and cons of these options, getting the consent from the patient. Then you have a delayed definitive treatment, where again you take a biopsy with or without a stoma or bypass, give the patient neoadjuvant chemotherapy, and then do a CRS HIPEC. All of these have its own pros and cons, but one thing that you must not do, just resect the primary tumor and then refer the patient to CRS HIPEC. Because when you do a radical resection, you are giving a lot of bare area in the abdominal cavity, which is seeding ground for pre-intraperitoneal cancers. And if you would recollect Sugar Baker's cell entrapment therapy, once these free intraperitoneal cancer cells that collect in the tumor bed are surrounded by fibrin, then they become impervious to your HIPEC. So this is what you must not do. You must not do only a resection of the primary tumor alone and then send the patient for CRS without it. So it is always better to avoid facing such a situation of incidental detection. So what do? Know that there are some high risk factors for colorectal cancer to develop peritoneal metastasis. What are they? Young age, E4 disease, no positive tumor, mucinous or signature cell histology, right-sided tumors, various the biology of the disease, poorly differentiated tumors, CMS4 subtype tumors, BRAF mutant tumors. These are all more prone to peritoneal disease. Then if the patient already has an ovarian metastasis or there's suspicion on CT scan, in this situation, what you should do, selectively plan a laparoscopy patients so that you can find out without a formal laparoscopy whether they have peritoneal metastasis, could estimate the PCI, take a biopsy and confirm, and then you have enough time for this. Then counsel, consent, and prepare the patient for definitive procedure. We were again discussing about the role of systemic therapy in CR peritoneal metastasis. Neoadjuvant therapy, as of now, there is no published randomized trial comparing neoadjuvant chemotherapy versus no-neoadjuvant chemotherapy. But the Cairo 6 trial is looking exactly at this question. They have published their short-term results, which say that giving neoadjuvant chemotherapy is safe and can induce some response in the peritoneal metastasis. Up to 28% pathological response they have noted in the patients who received neoadjuvant. And they also did not observe an alarming rate of progression in the peritoneal metastasis. Final results are yet to come out. Probably then we will have an answer whether you. Now, would you give adjuvant chemotherapy after CRS and HIPEC? There is no randomized trial, but there is this one publication from, I think, MD Anderson, which has shown that giving adjuvant chemotherapy improves the overall survival when compared to no adjuvant chemotherapy after CRS and HIPEC. Now, a quick word on prevention of peritoneal metastasis. As residents, you must be aware of these two trials, COLOPEC trial and the recently published HIPEC T4 trial. The COLOPEC trial was from Netherlands. They looked at preventive strategy of prophylactic HIPEC after resection of the primary tumor, but they did not find any difference in the peritoneal free survival, which was the primary endpoint at 18 months. Whereas the HIPEC T4 trial conducted in Spain showed that the 3-year loco-regional control rate was higher in the HIPEC group than in the comparative. Now, these two trials are not exactly similar, whereas the COLOPEC trial used oxaliplatin, the HIPEC T4 trial used mitomycin. There were differences in the inclusion criteria. So, the HIPEC T4 trial, however, did not show improvement in the disease survival or the overall survival. And the magnitude of benefit with HIPEC was absolute risk difference was only 9%. It is probably not very high enough to mandate a change in practice, but it has shown that adjuvant HIPEC has the potential to reduce peritoneal metastasis. Finally, a word on PIPAC. This is an emerging modality of treatment for peritoneal metastasis. Basically, you are generating an artificial pressure gradient, thereby enhancing the tissue uptake of the chemotherapy. And you're allowing a homogeneous distribution of the abdominal cavity. Currently, it is being used mostly as a palliative treatment in patients with extensive colorectal peritoneal metastasis who are not eligible for CRS HIPEC or those who have intractable ascites, and it is showing some promising results in controlling the ascites and prolonging the disease survival, prolonging the progression-free survival. But the future uses of this procedure may be as an adjuvant therapy in high-risk patient, or probably even as a neoadjuvant therapy in patients with established colorectal peritoneal. Now, I'll quickly move on to the second part of the talk, which is locally recurrent rectal cancer, which is defined as recurrence of rectal cancer within the pelvis after previous surgical resection. In spite of all the advances in surgery, TME techniques, and neoadjuvant therapies, still around 4 to 10% of patients who undergo radical surgery for rectal cancer experience a local recurrence. And local recurrence is associated with a shortened lifespan. Not just that, it has some debilitating symptoms like severe rectal bleeding, obstruction, fistulas, bad discharge, tenesmus, etc., which the patients can find very. But nearly 50% of such patients will have an isolated local recurrence, which may make them amenable to a potentially curative surgery. Therefore, it is important to detect such recurrences early so that you can salvage them. Now, we were discussing about the surveillance in colorectal cancers post-treatment. I'm sorry for this small print, but just to show you that various surveillance guidelines exist by different societies. Even within the US, there are some 5 or 6 different recommendations for surveillance. Basically, it involves rectal examination, CA testing, CT scanning, and colonoscopy at various intervals. Usually 3 to 6 months in the first 2 to 3 years, and then 6 months to 12 months in the next 2. This Cochrane database review in 2007 showed that intensive surveillance reduced the time to recurrence significantly. There were more curative surgical procedures in the patients who had an intensive surveillance, which led to an overall survival benefit after for intensive surveillance. However, subsequent to that, 3 large randomized trials have been published. ACT study in the US, GILDA study, and the Colofold study, all of which compared patients with minimal or less frequent follow-up versus more frequent or intense follow-up. And all these studies did not show an improvement in the overall survival or the specific survival with an intense survival. Even though the salvage rates for recurrent tumors with a curative intent was higher in the group that was followed up more intensely, they did not, this Cochrane, same Cochrane database into 2016, the review did not show an improvement in the disease-specific survival or the overall survival. It has to be taken with a pinch of salt. These trials are different in the way they were conducted. There were some flaws with the study. Like Dr. Pushtala correctly said, there is a benefit in identifying recurrences early, that they can be salvaged with at least a potential to improve their quality of life and hopefully their survival. Now, most local recurrences occurs within 5 years. However, with increasing use of neoadjuvant chemoradiotherapy, there is also a trend of delayed local recurrence. Nearly 3 to 5% of local recurrence occurs after 10 years. You all must be familiar with the German and the Dutch rectal cancer studies. The German trial, nearly 23% of local recurrences occurred after 5 years. That study, nearly 9% of local recurrences occurred after 5 years. So, which means that preoperative radiation may probably not completely avoid, but what it does is at least postpones local recurrence. Very important follow-up patients with rectal cancer who have undergone neoadjuvant radiation even beyond 5 years. So one thing you must remember, intraoperative perforation and circumferential resection margin. These are 2 very strong predictors for local recurrence. This is something which the surgeon can at least partly control. Positive circumferential resection margin is not always the fault of a surgeon. Sometimes even despite good surgical technique, the biology of the disease might be such that the patient might end up with a positive circumferential margin. Although nowadays the beyond TME approach and directed by preoperative MRI should ensure that the circumferential resection margin positivity rate should be less than 5%. Various surgical techniques like the TA-TME has been reported to have a higher incidence of local recurrences. Abdominal perineal resection has a higher local recurrence rate when compared to a low anterior resection because it has been associated with higher incidences of intraoperative perforation and positive. Now, how is local recurrence classified? There are various classifications, but the commonly used one is based on where exactly the recurrence happens. Maybe central or axial, which may be an anastomotic recurrence or a mesorectal recurrence or a recurrence after a local excision. Maybe an anterior recurrence where it involves the genitourinary tract. Maybe a posterior or a presacral recurrence, which involves the sacrum or the presacral fascia. Nowadays, we are seeing more of lateral recurrence, the lateral pelvic nodes, or in the soft tissues of the pelvic wall and in the lateral body pelvis. Some classification systems also add a fifth one, that is a perineal recurrence, which happens exclusively in the perineum. So this is just a diagrammatic representation of the classification of recurrence. So nowadays, there is a shift from central recurrence to a non-central recurrence. As I mentioned, more recurrences these days are seen posteriorly or in the lateral pelvic wall. How do you manage a locally recurrent rectal cancer? You need a multidisciplinary approach, includes surgery, usually some form of an exentration. This offers the best option for salvage and sometimes even a cure. Although 30 to 40% of patients who have a local recurrence are candidates for surgery with a curative intent, only around 20% of these patients agree to undergo radical surgery for the local recurrence. Means roughly around 5% of patients who have a local recurrence after treatment for rectal cancer eventually agree to undergo surgery, because the surgery is not a very easy one. The previous surgery, the fibrosis induced by radiotherapy, and the invasion of the recurrent tumors to the adjacent tissues increases the challenge of the surgery. Surgery requires a multidisciplinary team, including plastic surgeons, urologists, vascular surgeons, etc. In some situations, preoperative chemoradiotherapy may help, but in non-anastomotic recurrence, patients who have been radiated earlier, the role of preoperative chemotherapy is debatable. It has been shown to increase the complications, the readmissions, and reinterventions, but it may have a role in select population. Before embarking on managing such patients, you need to have a high quality MRI pelvis so that you can make a decision whether this patient is for surgery. Because you need to rule out other sites of metastasis. FDG PET scan is not the best tool for identifying a local recurrence, because post-radiation, post-surgery, you may have a false positive PET scan even a long time after the completion of treatment. FDG PET scan is more often used to rule out other sites of metastasis. PET MRI is an upcoming modality of staging patients who have a local recurrence. What is the role of biopsy? It is always preferable to try and take a biopsy of locally recurrent rectal cancer. It is easy if it is an intraluminal or an anastomotic recurrence, but if it is an extraluminal recurrence, it is not always possible to obtain tissue diagnosis, in which case suggestive imaging along with a very high CEA values could be taken as proof of recurrence. These patients need to be discussed in a multidisciplinary board. Then, aids accurately. Patients have to be counseled because they are going to undergo what could be a very morbid procedure, which may alter their quality of life significantly. You have to choose the patients carefully. They need to be fit enough to undergo such a major procedure like an exentration. Preoperative cardiopulmonary exercise testing is a very important part of preoperative workup. And these patients require rehabilitation which includes physiotherapy exercises, nutrition, as well as psychosocial interventions. Pelvics Collaborative is a group of surgeons with a special interest in pelvic exenterations. So they have come out with some good papers, which I would recommend that anybody interested in recurrent rectal cancers should read. Pelvic exenteration, they have defined as en bloc resection of at least 2 pelvic organs with subsequent reconstruction and or diversion of the bowel and urinary functions. Goal of surgery is clear. You have to achieve clear margins. Whatever it takes to achieve clear margins, setting adjacent organs or bone or muscle or nerves or even vascular structures need to be done if you have to achieve a clear margins. While these are potentially curative, as I told you, they are associated with significant morbidity. I'm not going into the specific details of surgery, but just to summarize, centrally located recurrences may sometimes extend into the anterior compartment and may require resection en bloc of the urogenital organs or the unconscious organs. The true anterior recurrence may require en bloc resection of the pubic bone. Posterior tumors often require sacrectomy, which may be a high sacrectomy if it is above S2, or a low sacrectomy if it is at or below the level. Lateral compartment involvement has probably the worst prognosis because surgery is very challenging and performed only by a very dedicated group of highly experienced surgeons. Can require resection of the iliac vessels, lumbosacral trunk or sciatic nerve, side wall muscles, or the ligamentous structures. What are the contraindications to surgery in locally recurrent rectal cancers? Previously, if you look at earlier papers, they used to have absolute contraindications, relative contraindications, involvement of major neurovascular structures, any tumor above the level of S2, lateral recurrences. These were all considered as contraindications. Right now, in experienced hands, most important factors that are absolute contraindications are presence of distant metastasis and a patient who is not medically fit to undergo such a radical procedure. So, what are the outcomes of surgery, especially pelvic exenteration for locally recurrent rectal cancers? Again, from the Pelvics Collaborative, there was a pooled analysis of more than 1,000 patients from 27 centers. They showed that an R0 or a clear resection margin could be achieved in more than half of such patients with a very low mortality rate of 2% at 30 days. Major complications, they had reported as 32%, but in most of the contemporary series, especially with complex bone resections and lateral wall resections, morbidity could go up as high as 70 to 80%. Median overall survival based on the radicality of resection varied from 36 months for an R0 resection, 16 months for a R2 resection, and 3-year survival rate was nearly 50% if an R0 resection was. They found that the 2 important factors that influenced overall survival after pelvic exenteration for a locally recurrent rectal cancer were achieving negative margins and bone resection were indicated. So, is there a role for non-surgical management? While I told you that an R0 and sometimes even an R1 resection offers a chance for potential cure, 5-year overall survival between an R2 resection and a non-surgical treatment is not greatly different. So, there is no role for a palliative surgery or a R2 resection in a locally recurrent. Patients who have you anticipate that they are likely to have an R2 resection, it is better that they be offered a non-surgical treatment rather than surgery. So, as I told you, re-radiation is now being increasingly practiced for patients who have already received radiation while they were undergoing treatment for the primary tumor. It is being shown to be feasible and it may provide some avenues for cure and definitely for palliation. So, the important things to remember while planning radiation is to use small radiation fields through the bowel and bladder to the extent possible, and use hyperfractionated doses up to 40 gray. Carbon ion radiation therapy is probably what the future holds. It is an exciting form of therapy, quite different from the proton therapy, and it has been shown to have a reasonable 3-year survival of 80% in patients with locally recurrent rectal cancers who are not amenable for surgery. So to summarize, locally recurrent rectal cancer requires a multidisciplinary treatment approach, and it is best managed in high volume experienced centers. Treatment and prognosis depends on the site and the type of recurrence. Two important factors for achieving long-term survival are an R0 resection and bone resection where required. So you must remember that just by doing a radical surgery does not always guarantee a clear margins. So such a surgery must be balanced against the risk of post-operative morbidity and deterioration of the quality. Surgeons who undertake such radical procedures must understand the pelvic anatomy, must have a detailed preoperative plan, and ensure adequate reach. And radical surgery may lead to high risk of post-operative complications and often a low. I think that concludes my talk. I have just scraped through the surface of both peritoneal surface malignancies as well as locally recurrent rectal cancers in the interest of time. I've tried to cover what I feel is important to the postgraduate students. For those of you who are interested, I urge you to read more. There's a lot of literature, and enrich your knowledge on both these. Thank you.
Thank you very much, Ramakrishnan. That was just comprehensive and wonderful. Truly, all of us learned a lot. Aditi, you are there? Aditi, can you share the screen? Aditi? Yes. There are a few queries for both the examiners. The students can relax and watch the examiners answer questions now. Now, how do you counter opinions against CRS HIPEC in an MDT discussion quoting Prodige 7?
That's a really tough call for the surgeons, how to convince medical oncologists on performing a HIPEC. So one way is to provide the facts about what the possible what went wrong in the Prodige 7 trial. One was that, as I already mentioned, they used oxaliplatin for 30 minutes, which is probably not the best agent and timing to be used for HIPEC in colorectal cancer. Many colorectal cancers have been shown to be of the CMS4 subtype according to the consensus molecular classification. And CMS4 tumors have been shown to be resistant to oxaliplatin. So that is one way you can put forth your argument. Another thing is many patients in this Prodige 7 receive neoadjuvant oxaliplatin. That could have probably led to the development of chemo-resistant clones, which did not respond well to oxaliplatin when given intraperitoneal. So you could argue that probably we will not use oxaliplatin. Instead, we will try and use mitomycin, which is a safer agent and does not cause the problem of bleeding, and which has been used in other peritoneal malignancies. And you could also say that, look, cytoreductive surgery anyway needs to be done. I'm not telling you that we will definitely do HIPEC, but we would keep it in the back of the mind. We will take a call on table If the PCI score is very high, the Prodigy showed in a subgroup analysis that HIPEC worked best when the PCI was between 11 to 15. So you could tell them that I would not do HIPEC if the PCI is very low. I would not do HIPEC if the PCI is quite high. But please consider HIPEC if the PCI is between 11 to 15. That is how we try to convince medical oncologists in the MDT. I don't know if anybody has any other ways to.
Bhavna, you want to add or differ?
Hello.
Bhavna, yes. What do you do? You continue doing HIPEC or not?
Sir, after Prodigy 7 trial, I think there was a paper which is called as is the road is over for the oxaliplatin, because there is a doubt about the efficacy of the oxaliplatin in Prodigy 7 trial. And in a subgroup analysis, probably the HIPEC was offered to the PCI, which was a high score. And third, the neoadjuvant chemotherapy given in form of oxaliplatin, which might lead to the chemoresistance at the time of when oxaliplatin was given for the HIPEC. So these are the 3 points which I remembered. Probably I think the new molecule will be think of is mitomycin after the Prodigy 7 trial. This is what I think, but we require more data to support the other agent.
Till then, you continue to do it in select situations. You select your patients and do what Ramakrishnan has said. Yes, thank you. What is the accuracy of laparoscopy in assessing problem areas of abdomen in CRS? Ramakrishnan actually told the students that while he was discussing. But anyway, just for completion, please tell us what are the areas which are a problem and how do you circumvent them?
So, properly done laparoscopy with proper walking across these walking small bowel will definitely identify disease in the base of the mesentery or in the serosal of the small. There are some areas that you should you may miss disease. One is in the just the left of the DJ flexure. Unless you look for it, you will probably not find it. Second is behind the caudate lobe in the inferior vena cava and the diaphragm, which you have to open into the lesser omentum. Identify that. You have to also look into the lesser sac, otherwise you might miss disease in the lesser sac. So these are the problem areas in a virgin abdomen where you could potentially miss peritoneal disease. On an average, the discordance between a laparoscopic PCI and a PCI assessed during laparotomy, the difference is score of 2 to 3. This is what has been published in the literature. But there is one Dutch study which says that even after a laparoscopic surgery, you might miss peritoneal metastasis in, if I'm not mistaken, I think in almost up to 20% of. That is just a one-off study. I'm not sure whether there has been any other studies that corroborate that. As of now, laparoscopy is the gold standard, and you might underestimate the actual PCI by a score of 2.
In addition to this, you mentioned when there is a peritoneal metastasis attached to the anti-abdominal wall and the colon is, I mean, the small bowel or the large bowel is also stuck to the anti-abdominal wall. These are the places where if you put a laparoscope port or a scope, there might be chances of having an injury to that. And we can walk through the small bowel, but sometimes there will be inseparable adhesions are there. So this can create a problem in diagnostic laparoscopy.
Now, this is not an uncommon situation. HIPEC not being available is very common in most parts of the country, but the surgeon has the ability to do it. Would you consider EPIC in these situations?
I wouldn't. I have not come across any great evidence to support EPIC in colorectal peritoneal metastasis. It might be an easy procedure to do, but it is not without problems. And in the absence of reasonable quality evidence, I wouldn't consider doing it. I would be more focused on doing a proper cytoreductive surgery rather than adding it.
Anything, Bhavna?
I think the same answer. If IPEC is not
Yeah.
available, one should go for the cytoreductive surgery. But there is one contradictory finding against the HIPEC is if you do alone a cytoreductive surgery, if you don't add a HIPEC, if the patient is candidate for that, and because of unavailability of HIPEC, because we open a lot of deep spaces in case of a cytoreductive surgery, so the leftovers tumor cells may implant and may create a problem if you don't add a HIPEC. So, but if when there is not available, then the cytoreductive surgery is the only option we have.
So no EPIC as it stands today. Okay. And the last one is TNT protocol advisable in recurrent rectal cancer setting?
It is currently available for the locally advanced rectal cancer. I'm not aware about the recurrent rectal setting, and it's still also in the TNT protocol is if you, if not become a standard of care, it is now the new papers are coming up, but especially not for the recurrent rectal cancer setting.
And radiation alone is debatable in the setting of a recurrent rectal cancer. If the patient has already received radiation. So total neoadjuvant protocol, I don't think is an advisable unless it is not used as a neoadjuvant, but just as.
And then when you are discussing re-radiation, Ramakrishnan, how much duration would you want to do that 40 gray between the first and the second?
Hyperfractionated, so definitely it will be a duration will be short.
Not the duration of the treatment, the duration between the two treatments, the first radiation and the second radiation.
I'm not sure whether it would differ between, between the first radiation and second radiation.
Yes.
So, ideally, 2 years is the minimum that most radiation oncologists would consider between primary radiation and re-radiation. More conservative radiation oncologists would probably say, I wouldn't irradiate re-radiate patient if he's had radiation within 5 years. But 2 years, there are papers which say within 2 years, beyond 2-year gap is sufficient for.
But most would prefer longer the better, is it not?
Yes.
Yes. Wonderful. So that brings us to the end of this excellent session on peritoneal metastasis and recurrent colorectal cancer. We have our advisor, Rajgovind Sharma, another great academician, waiting to thank you all. Rajgovind.
Yes, sir. It was a wonderful learning session. On behalf of IASO, I would like to express my gratitude to all, especially to the esteemed experts who have made this masterclass such a great success. Dr. Ramakrishnan, your expertise and insight have provided us with a deeper understanding of this complex topic, and we are truly grateful for your participation. I would like to extend my appreciation to Dr. Bhavna Parikh, our moderator, for skillfully facilitating the discussion and ensuring that the session flowed smoothly. Your expertise has contributed significantly to the richness of the learning experience. Both the examinees, Dr. Pushkala and Dr. Pratham Batra, did well. Just a word of caution, do the simple first and then go unless you are prodded by the examiner, do not jump onto the advanced things. I would like to thank Dr. Arnab for his introductory remarks and who said the ball rolling. Special mention for the man behind the show, Dr. Rao and Dr. Shukla for organizing this masterclass. Your dedication, meticulous planning, and attention to detail have resulted in a well-structured and informative event. Your commitment to advancing medical education is truly inspiring. Lastly, I would like to thank all the participants for attending. It is the main motto of IASO to enhance our knowledge enable the residents to do well in exams, and ultimately to improve patient care. Thank you once again to everyone, and I look forward to seeing you at the next masterclass. We would be happy to have your feedback and to make it more useful and fruitful to all. Thank you very much.
Thank you so much, sir. Thank you so much.
Thank you.
Thank you, all of you.
Thank you, sir. Thank you.
Thank you.
Good night. Take care.
Thank you. Thank you.
See you a fortnight later. Thank you. Bye-bye.
Thank you. Thank you. So we close the session.
Thank you.